Hello, everyone. I'm Dr. Carmen Pugliafito, and today I'm happy to welcome back to Retina Synthesis Dr. Carl Danzig of Fort Lauderdale, Florida. Carl, how are you doing?
I'm doing great. Thank you so much for having me.
You gave a great talk at Angiogenesis 2026 about the Avenel X trial of Faricimab for Neovascular AMD. Can you tell us a little bit about this trial, which is the longest, I think, trial of uh, Faricimab in this disorder?
Right. So Avenel X was the extension of Tenaya Lucerne, which enrolled treatment naive patients with wet AMD. At year two, all the patients that wanted to go into the extension did. So you had patients that were randomized to faricimab or randomized to a aflibercept in the parent study, all received faricimab in the extension study in a treat and extend fashion. There's a couple beautiful things about this extension trial. One, you had an 80% transition from patients who completed Tenaya Lucerne to enroll into Avenel X. So over 1,000 patients are in the extension study. That's 80% retention into the extension. That's pretty robust. The beautiful thing that I like about it, people ask me the question all the time when I would present the Truckee data. They say, well, what about loading? What about reloading patients when you're switching from one drug to faricimab? Well, here we have real data from this extension trial where you had patients in the parent aflibercept arm switch over at month 25, essentially, to faricimab without reloading. So granted, there are other studies going on that are looking at loading doses, but we actually have great data here. So those patients that were able to transition to Avenel X did quite well. The visual gains that we saw in Tenaya Lucerne were maintained. In fact, at the end of year three and the end of year four, 75% of patients who entered with 20/40 vision ended at those years three and four with 20/40 vision. So the visual gains that were seen early were maintained by and large. The CST reductions, similarly, those robust CST reductions that we saw early on in Tenaya Lucerne were maintained through 4 years, where at the end of the study, 78% of patients were on extended dosing, Q12 to 16 months. So what we see here with Tenaya Lucerne transitioning to Avenel X is continued efficacy and durability of faricimab.
So, what percent of eyes were out at Q12, Q16 weeks?
Well, 78% were out to 12 or 16 weeks. But really, one other analysis that I presented that I really find intriguing, and though it wasn't offered in the study, is 51%, about 51% of eyes would have been eligible to go to Q20 week dosing. Now, that wasn't allowed,
Hmm.
and that's not part of the label. But if you were to do that analysis of how many patients showed no disease activity at week 16 that would have been extended if it were allowed, over half. So that's another thing about faricimab that we don't really talk about is how many patients go out more than Q16 weeks. And the Avenel X study showed that potentially, 51% of patients were able to demonstrate no disease activity at the week 16 visits.
That's extraordinary. And this is so different than the first generation of anti-VEGF agents, where after initial improvement, there was inevitable decline in vision.
Well, we know commonly, when you do these extension trials, those visual gains that are seen at the beginning of the extension are just not maintained because patients are monitored less, they get less frequent injections, and they just kind of drop off. So this is a robust data set of patients that entered and finished the trials at years three and year four that maintain the vision. So you're absolutely right. So having these newer generation drugs are able to give patients more hope, able to maintain their vision longer. And frankly, no one's raising their hand for more needles in their eye.
Yeah. Well, one of the discussion items for TKIs is to decrease treatment and treatment burden. How do you think TKIs fit in with the prevalence of longer duration drugs such as faricimab? How do these fit together?
We all know that we have these hard to treat patients, right? So even in the Avenel X study, what 78% of patients were able to go Q12 to Q16 weeks. But what about those other like 22% of patients? So more than 1 in 5 patients were at every 8 weeks or needed potentially more than that. It wasn't allowed in the study, but we have those patients in our trials that just can't get out to even every 8 weeks. We have some that are Q6 weekers. So having a TKI is going to be super valuable to our patients because every patient is an individual here, and not everyone fits into the cookie cutter recipe of a clinical trial. So I look at TKIs as complementary, supplementary. It's not a replacement. So when you're able to have a different mechanism of action, and the TKIs work on the intracellular space as opposed to the extracellular ligand, so they're able to have broad effect on the intracellular receptors and hopefully create even further vascular stability, including visual stability after those gains are achieved, and keeping needles out of people's eyes as frequently as they were. Furthermore, with some TKIs, you may not have, the loading doses that we would see in other trials. So, and we're going to see whether it's going to be for, wet AMD, and there's some TKIs that are in DME trials or DR trials, and how that's going to work. Because we know when we look back at like Yosemite and Rhine, there was about, I think, 22% of patients were treatment experienced, but then they had to go back to reloading in those trials. Here with TKIs, you may not have to reload. We're going to see. We're going to learn more about it. But I am optimistic that the trials that are going on now will hopefully, read out positively, with their phase 3 data, and we can have another safe product on the market for our patients.
It's interesting that your observation about the absence of loading doses in the switch over from aflibercept to faricimab. I think that the loading dose concept is still, to me, a bit controversial.
I agree. And I think there are actually clinical trials going on, sponsored by Genentech and Roche, looking at loading doses. So that's something that has been a point of discussion for a long time. And the question is, because we just don't really know sometimes what is best. Now, some patients may really need those loading doses. I have a feeling that most don't. What I commonly do, and this is my own, practice pattern, is if someone's on a certain interval with, we'll say, aflibercept, and we're switching that to faricimab, I'll keep them on that dose or that dosing interval, 6 weeks, 8 weeks, for a couple doses, and then extend them further. But I have colleagues that say, hey, we're just going to, put the pedal to the metal and extend them quickly.
So, are there any biomarkers to tell us which patients are long duration candidates or not?
This is the, $64,000 question here, Carmen. You know that. I would love to understand this better myself. I have patients that do best with a bispecific inhibition with faricimab. I have other patients that need a higher molar dose of anti-VEGF with aflibercept 8 milligram. I don't know why some patients do better with one and not the other. One analysis I do like, and it's more so we see in the DME and the RVO trials, is macular leakage. And I think that macular leakage and absence thereof after loading doses. Now in the RVO trials, it was 6, head to head, 6 faricimab, 6 aflibercept in the Balaton Camino trials. And that, repeated fluorescein angiogram at week 24 as a pre-specified exploratory endpoint looked at macular leakage. And those who had absence of macular leakage at that point were more likely to have extended dosing later. But no one's really measuring macular leakage in their clinic, and certainly doing added fluorescein is not helping our efficiency.
Yeah. Well, this has been a great discussion that showed the tremendous paradigm shift in the world of anti-VEGF therapy from day one in 2005 to 2026.
I agree. And then the thing about it, there's a couple things I want to make a couple points about here. Um, Innovation and investment is continuing and ongoing, and it's such a great time to be a retina specialist. I'm so privileged to be in this field because in the end, I love the science, I love the innovation, but the patients are the ones that are going to benefit the most long term. And we are advancing this field every single day. The other point I'd like to make about the Avenel X data is we have now 4 years of safety data. And we're looking at safety more and more closely with every single trial. And that's going to happen with all the trials that are ongoing now. It happened in the past, and now they're under even more scrutiny. And I love that we have 4 years of good data with no new safety signals. And I'm looking forward to seeing what these new products are going to show with safety, because in the end, we love the idea of durability. We love the idea of maintaining vision, but we certainly don't want to compromise safety. And I think that by and large, we're having, a lot of, eyes on the ball with this across different disease states through numerous different trials.
Well, great. Thanks for joining us today on Retina Synthesis, Carl.
It's been a pleasure and honor. Thanks, Carmen.